All right, and we are on. It's been a little bit since the last installment, but I am back again with Dr. Jan Ulbrecht. Today, we're going to talk about male hypogonadism, which is everyone's favorite topic, including yourself. I know that. Um, how's it going today, Jan?
It's a good day. It's a beautiful afternoon here in Happy Valley, except for the football disaster.
Yeah, yeah, we won't comment on that, but
Okay, no comment.
anyways, so like most of these kind of episodes have gone so far, we're going to just go into the basic fundamentals of the physiology, then the pathophysiology, treatment, and whatnot. So, yeah, why don't you tell us what exactly, kind of at a basic level, what is testosterone? What's the function of testosterone, and why is it important for men specifically?
Well, okay. So testosterone is first and foremost the hormone responsible for sexual differentiation throughout the body, maleness, essentially the things that we associate with men, including first and foremost, of course, sexual function, sexual drive, um, but also the differences that are obvious in terms of muscle mass and voice and hair patterns and all those things, and also some of the behavioral differences. This might get a little controversial. I hope not, but men are different from women. Women are different from men, and in their behaviors, and some of that is almost certainly attributable to testosterone.
Absolutely. And just basic, touching on the basic feedback systems, just like how we talked about with the thyroid. Do you just want to talk about the basic signaling hormones that play a role in regulating testosterone levels in the body?
Yes, absolutely. So many of the hormones that we talk about, have talked about, will talk about, are controlled by the pituitary gland, which is in turn controlled by the part of the brain called the hypothalamus. And the way fundamentally the way this works is very very similar across these hormones. So there is a message from the hypothalamus to the pituitary, which sends a message in this case to the testes to make testosterone. And as we've discussed with the thyroid, we can take advantage of that by tapping into that message. So when the testes fail, the pituitary and the hypothalamus perceive that as inadequate testosterone level and will send out more message. And so that's very useful. And in that one situation, it's relatively easy to make a diagnosis of a problem if the testes fail primarily.
Okay. And just for those listening at home, the hormones specifically that come from the pituitary are called luteinizing hormone and follicle stimulating hormone. And those two separate hormones stimulate the testicles in different pathways to produce and release testosterone into the blood. And then furthermore, that's how it's regulated on a very simple level. And I forgot to mention in the beginning, if this is the first time you're listening, Dr. Ulbrecht is actually a real endocrinologist, a real expert in this field. So we're not just kind of making this stuff up. And I am his colleague. I'm the PA that works with him. So okay, so we talked about the basic stuff. So that's how it works, and there's no problems and whatnot. So going into hypogonadism, which is low functioning gonads, do you mind touching on the basics, kind of signs and symptoms of who you would be suspicious for may have this disease, and who should be evaluated if they're feeling a certain way?
So as I think we've talked about with the thyroid, often the symptoms are non-specific or sometimes non-existent or sometimes not perceived by the person. And so that's a challenge. But in the classic sort of full-blown situation, a person will first and foremost experience low libido. in other words, low sex drive. As a consequence of that, sexual function may be impaired. So if you don't have much drive, the function suffers. And then loss of muscle mass, poor beard growth, and then sort of loss of poor energy, maybe a little bit of depression or feeling down, feeling blah. And those would be the major symptoms. Again, as I said a moment ago, sometimes these are not perceived by a person as a problem. Sometimes they are genuinely so. When I say not perceived, when you treat a person, they say, "Wow, that really was a problem. I didn't feel so good. I didn't realize it." Or it may genuinely not be a problem where you treat somebody and nothing changes. They just felt just fine. So a lot of this is something that we talk about endocrinology quite a bit, that the symptoms are not necessarily clear cut, but that would be the classic symptoms that we run into.
Right, right. And what may also accompany that with the low libido is erectile dysfunction, whether that just may be blatant, you know, they get nothing at all, or they have difficulty maintaining, which is also in part a big part psychological too. So that's important to differentiate as well.
And one thing we didn't say is we're talking about adult acquired, or what I was describing would be
Mhm.
somebody who has gone through normal puberty and
Right.
had normal levels and normal pubertal development. When testosterone is deficient during puberty, then there is lack of pubertal development, um, and or delayed puberty, or impeded just partial puberty. So that's also worth saying.
Right, right. Actually, that was my next point. So good thinking there. So part of that, yes, like you said, is an adult male who has gone through the normal puberty process, and then um, I guess we can get some of the genetic diseases out of the way. That way, we can kind of get, because this applies more to the acquired male side. Do you want to just briefly talk about some of the genetic diseases that people have, like Kalman syndrome and Klinefelter's and whatnot, and why sometimes those people get diagnosed much later in life and whatnot?
Yeah, so those are the two big ones. There are a lot of other unusual things that I've probably never seen, never will see, but the two ones that are pretty common. Klinefelter syndrome is by far the most common, and that's a genetic defect in the sex chromosomes. And there are variants on that, and the severity of the deficiency can be partial. So boys, men may go through sort of partial puberty, partial development, or even normal development initially, but then develop a testosterone deficiency in their early 20s or later. Um, and that is easy to diagnose because that is a primary testicular failure problem. And so, as we were discussing earlier, particularly the hormone LH, which is the primary one responsible for testosterone, that it's going to be high. As we talked about before, the brain, the pituitary, perceives that as a problem and will send that signal. So that's really easy to diagnose. Um, Kalman syndrome is much less common, though we do see it occasionally. We probably have in our practice, two or three people like that, maybe.
Mhm.
Um, and that is a genetic problem where there is a primary defect in the hypothalamus pituitary, and that signal fails. And that's much harder to diagnose because, in childhood, that signal is also absent. That's why boys don't develop puberty till they do. And it's hard to measure that signal. So as a young man, 14, 15, 16, is not going through puberty, it's hard to prove that this isn't just regular delayed puberty, that in fact there is a problem and it's not going to happen. And as you and I know, we don't do too much pediatrics, but that's the essence of that. Um, and there's a little quirk about that. The same developmental defect in the brain can also cause lack of development of the sense of smell. And about half the people with this will have both lack of sense of smell, which makes it much easier to diagnose then, as well as failure of the pituitary hormones to start puberty and continue puberty. About half, interestingly enough, in the same family can just have the loss of smell, and that's too many, right? So it's not. I'm obviously not adding, and it doesn't add up to 100%, but some significant number can have just the loss of hormone function. Some will have both, and some will have just the loss of smell. But again, this is pretty rare.
Right. Now, aside from, genetic predisposition where people will never have um, adequate androgen in the blood unless they're actually treated, we're going to get into, I guess you can say, quote unquote, reversible hypogonadism in some instances, which is a huge, huge, huge topic and issue right now, not only in endocrinology, but in medicine in general, just because the prevalence of obesity and diabetes and substance use disorders and whatnot. So we can get into that more. Now, do you mind explaining and going into kind of the process of why so many men now, especially those with diabetes, are showing up and they're having lower testosterone levels, at least measured, and they're not feeling so great, and so on.
So this is the Pandora's box, and it really starts with measuring testosterone. And as we've discussed with thyroid disease, measuring any blood test actually, but certainly when it comes to hormones, is fraught with challenges for several reasons. One is that the tests themselves are technically difficult, and you may get an answer that isn't exactly accurate or totally reflects what's going on. But also because we don't really know exactly what is normal for any given person. So before I begin to talk about this epidemic, and you're right, this has become a real issue, and there are some really good reasons for what we're seeing. Really beginning to quantitate or document or prove in any one person that there is a problem is a big challenge. Depending on the assay, the quote unquote normal testosterone level is between about 300 and 1,000 ng/dl, which is a huge range, right? I mean, how
Huge
is that?
range.
How
Yeah.
is that possible? Now, there are some nuances to that to do with measuring free testosterone and total testosterone, but let's leave that aside for the time being. Most people think about the total testosterone as the number, and as an approximation, it's a reasonable thing to consider. But still, how is it possible that quote unquote normal is 300 to 1,000, give or take? And as we discussed with thyroid disease, for some people, 300, 400 is absolutely spot on, perfect, and they feel great, and they're not having any problems. And some people can be quite miserable. There's also a notion that testosterone decreases with age, which is actually not really true. There is a peak to testosterone around the age of 30, 35, but it actually doesn't drop too much after that on average. The variability increases with age, so you'll see a lot more men with really pretty low testosterone levels as we get older, but also more higher testosterones, oddly enough, as we get older. So you can't even say, well, and we see this often from patients, well, I'm 30, my testosterone shouldn't be 400. Well, again, as you look at the reference ranges, it could be 400, and that could be just fine.
Right.
Again, so age is not really a clear factor in this. Another challenge is that that variability is not necessarily associated with any kind of symptom. So now, one thing that we do know from men who develop primary testicular failure, that is when the testes themselves fail, and we have that brain signal, that LH, to tell us, you can have men who have testosterone of 300 or 400 and a high LH, which is telling you that, in fact, the brain doesn't see those levels as adequate. But as I said a moment ago, um, um, there are people who have those levels who feel perfectly fine. Now, as we talked about when we started, is that because they're missing the symptoms? And if we were to treat them and make the testosterone higher, would that make them feel better? Or are they truly just not sensitive to those effects? But is that testosterone, in fact, somehow still too low? So there is no easy answer to this. And I think what we're painting is a picture of why this is so challenging in practice. Now, there are lots of reasons for, and most of what we see as low testosterone these days is not primary testicular failure, which is the easy thing, as we just talked about, right?
Right.
If the LH is high, that's pretty straightforward. But I would say 99.9, quote unquote, again, because how is that defined, don't have primary testicular failure. They have some symptoms, and somebody measures the testosterone and it's 350 or 400, or even 425, and they don't feel great in some fashion. And they'll usually conclude, well, that's too low for me or too low for my age or whatever. And they may be right. And
Right.
but they may not be right. And so, as you know, what we end up doing is having a lot of conversations with people. And if they really want to try testosterone and the symptoms are consistent, we'll often do that because that's often the only way to figure it out. Now, none of that answers the question that you actually asked me, which is why do we see more men complaining of symptoms and potentially have testosterone measured than we used to 10, 20, 30 years ago. And that's a multifactorial issue, right? So one is undoubtedly that the drug companies like to sell testosterone. And so there's been a lot of promotion of, get your T measured. If you have these symptoms, get your T measured, right? So that's part of the reason we're seeing so much more of it, which doesn't necessarily mean that it isn't true or doesn't exist, right? It just means that we're seeing a lot more people with that complaint, in part because the advertising is out there. Get your T measured. But there is also objectively some evidence of lower testosterone levels over the decades, and there are probably two reasons for that. One is, as you mentioned, obesity. So low testosterone is part of the obesity syndrome. And we'll talk about that some more in a minute. But low testosterone may also be a consequence of these endocrine disruptors. We hear about the chemicals that we ingest in various ways that are interfering with hormones. So that may be another reason that there really is less testosterone. So then maybe testosterone levels may be lower. They're still in the reference range. And we're picking it up a lot more because there's a lot more advertising directly to men saying, get your testosterone checked. So I'm going to stop because I think I've said a lot more than what you asked me, but maybe try and redirect to us where do you want to go next with this?
Right. I guess some of just the basic mechanisms of why obesity and metabolic syndrome actually drive men to have lower testosterone levels, and how in some circumstances, or I should say not circumstances, but some cases, that we can actually reverse those things without treatment. And then there's the question of, help treating them to kind of get the first domino to get rolling. So I guess from a mechanistic standpoint, why does obesity, metabolic syndrome, all of why do these problems drive low testosterone?
I'm not sure that I actually know the answer to that, or that anybody knows the answer to that exactly, why it is that obesity and metabolic syndrome, we'll talk about in just a minute, is associated with lower testosterone levels. But it is what we call a central mechanism, which is, in other words, there is not the messaging from the brain is what's deficient. Now it is reversible, in that if you lose weight, then these levels improve again. And so in that sense, we know there is a cause and effect there. But what's challenging about it, it's also works the other way. So there's now ever increasing evidence that if you treat people like that with testosterone, you can actually begin to reverse some of the metabolic syndrome phenomena. So we haven't defined metabolic syndrome, but metabolic syndrome is that association of diseases or problems that it first of all can cause diabetes, and diabetes can be a part of it, but it also comes with high blood pressure, high triglyceride level, increased risk of vascular events, heart attack, stroke, increased risk of cancer, and it seems to be dependent on central obesity in particular. So abdominal obesity, visceral obesity, which is part of the obesity epidemic. So again, we don't know exactly why that happens, but it does. There's a variety of reasons that have been looked at. But like I said, there are several studies now showing that if you then correct the testosterone, not in everybody, in fact, it's probably a minority. Well, in everybody, there may be some benefit. It's probably a minority that have major benefits. But we have certainly seen patients, again, who have dramatic benefits metabolically off testosterone in this situation, right? So I'm thinking of a particular patient who we tried, because he was interested in trying to stop testosterone. He was able to get off the testosterone. The testosterone levels didn't drop dramatically, but he gained about 20 pounds. His blood sugars became much higher. His blood pressure became much higher. He went back on the testosterone and everything improved again. So it's an interesting vicious cycle that we run into, this relationship between obesity and the metabolic consequences of obesity and testosterone.
Yeah, absolutely. And in part, the measurements definitely do get skewed too because of the aromatase issue. Um, and for those who are listening, adipocytes or fat, the fancy word for fat cells, are very rich in an enzyme called aromatase, which actually speed it. It is the mediator that converts testosterone to estrogen. So obviously, if you have a ton of fat cells, that process is going to be happening much more quickly than it would if that weren't the case. So that adds in part to why the measurements often are much lower too, in part to the secondary effect. Okay, so we kind of went through all that, and then the issues with, not really issues, but the challenge of the testing and whatnot. We talked about treatment a little bit. In some instances, we discuss patients who, we could offer a trial and whatnot. But when do you kind of really look? What are some things that you, from the endocrinology standpoint, that you see or definitively say that this person needs to be treated with testosterone outside of the destructive processes, the testicular torsion and testicular injury, injury from chemotherapy, the genetic diseases, and so forth?
Well, again, any primary testicular problem is, first of all, easily diagnosed, and second of all,
Right.
should be treated, because the body is telling you that there is a problem, right? The brain's monitoring that level and saying, that's not adequate. So that's easy. That's really easy. One thing that we didn't talk about, so as I did say, I think that probably 99.9% of low testosterone patients to cases, problems that we see are central, not a problem of the testicle, but a problem of the messaging from the brain and the whole area of obesity and metabolic syndrome and so forth. However, it is possible to actually have a physical problem with the pituitary. pituitary tumors will present this way. And or something called empty cell will present this way. And again, as you know, Isaiah, we are quite meticulous when we end up seeing somebody who has low testosterone, or we think they have a low testosterone. They really respond well to testosterone. That's a central problem. That's a problem with the brain. We're pretty meticulous about looking at the pituitary physically with an MRI. And, I would guess maybe in 1 out of 100 patients or something like that, maybe it's a little bit more than that, 1 in 50, we do find a specific problem with the pituitary that, is obviously worth treating as a separate issue and worth understanding as a separate issue. Pituitary tumors can cause other problems. So there's a lot of willy-nilly prescribing of testosterone. We have a lot of patients who come and see us who get testosterone elsewhere, and I know you want to talk about that, and I think it's important. And typically, the scenario is somebody comes, goes onto an online clinic or something like that, and they'll measure the testosterone, and it's going to be 350, 400, 450. So, yeah, this is too low for you. Here is some testosterone. And then they come to us and we say, well, yeah, that could be, but, have we really excluded a specific pituitary problem like a tumor? And about 1 in 50, we probably find somebody as something like that. So to answer your question, first of all, it's really important to do to make sure that there is not such a problem. And second of all, that would be another case where treating is a pretty straightforward proposition, because there's a fairly objective evidence of there being something physically wrong with the pituitary. So that's the other area where it's relatively easy. I would say the area where it's sort of intermediate are the men who have either metabolic syndrome or a combination of metabolic syndrome and narcotic dependence or something like that, which also suppresses the axis. And the most challenging are the men who are relatively young, relatively healthy, had relatively few symptoms, were prescribed testosterone somewhere, now feel much, much better in some fashion. And there really is very little objective evidence of a problem other than that they feel better. And now what? So again, a long answer to your question, but please pick it up and redirect us again.
Right. And yes, that's a good point you made that I forgot to mention earlier, is that long-term narcotic opioid use will also cause central disease and result in hypogonadism. Also can severely suppress the cortisol axis as well. So a lot of messy problems come with that. Okay, so why don't we talk about treatment? We've kind of beaten that horse a while about the diagnosing who might have it, all of the symptoms and whatnot that may or may not show up. So we can not definitively conclude, but say with good good evidence behind us that most people who develop hypogonadism, most men who develop hypogonadism later in life, most of them struggle with problems like obesity, diabetes, and metabolic syndrome. Occasionally, we'll get a fish in there who kind of just comes out of the blue and they just don't feel great, and they take testosterone and maybe their levels go from 400 to 750 and they feel like a new person. But like you said, it's really hard to prove that they have a deficiency, and you get on a slippery slope when you start doing trials like that. Anyway, so we'll go into treatment. So what are the treatment options for people who have a legitimate deficiency that is not reversible and whatnot?
So standard treatment is testosterone itself, and that's where most of the research is. There are some treatments out there. They're not testosterone. They try and increase the person's own testosterone level, or reduce the estrogen level, as you were talking about. But I think those studies are much less. There are many fewer of them, and I think the standard answer to a truly deficient testosterone situation is to give testosterone. Now, the challenge with testosterone is that until very recently, well, maybe 5 years ago now, it was not available as a pill. It has been available now for about 4 or 5 years as a pill. Unfortunately, most insurance companies don't pay for the pill, so it's still essentially not available. And then the other preparations, the most popular preparation I think that we use the most and that is most user-friendly is the gel, which is like a hand lotion bottle that you squirt the lotion out of and apply it to the skin. Let it dry on the skin, is absorbed that way. There is a multitude of other preparations. There are skin patches like a Band-Aid. There's testosterone you can use like a deodorant in the axilla, in the armpit. There's testosterone that you can use like a chewing tobacco, a variety of things. And of course, the one that's still by far the most popular and easier to get access to is injectable testosterone that can be injected once or twice a week, either in the muscle or under the skin.
Right. And like you said, at least in my time in the clinic, the injections are long and by far the most consistent and typically give some of the better results. With the gel, I would say being not far behind, but the other remedies or the other methods of treatment aren't, like you said, they're either not covered, they're extremely expensive, and they don't necessarily give the most consistent results when it comes to predictability. And then when you start treatment on someone, what are kind of your goals after that? Are you monitoring levels, symptoms, both, and what's your perspective after you start treatment? What do you look for in that person?
Well, one thing that's worth talking about is the behavioral aspects of treatment, right? Particularly in young men who had never received full dose testosterone because of one of those genetic issues, but also in younger men who may have had full puberty but then hadn't had testosterone for a while, again because of a pituitary problem, pituitary tumor, something like that. And so those are situations where it's very clear that a person should get testosterone that's deficient. There's just no question about it. The other effect that we hadn't discussed is the adverse effect on bone health. Again, this is why men have stronger skeletons than women. But the behavioral aspects can be real. And again, most of this research is not open and shut, and there are many nuances to this, in the sense that some people really have major effects and some people have no effects. But testosterone is at least to some extent to what makes men more aggressive, more forthright, more sort of ready to fight. One does hear about people who abuse androgen, football players and so forth, really becoming violent. We're not talking about that, but testosterone in the situation where you go from very low to normal can change the way a person behaves. And for some people, it's welcome. For some partners of people, it's welcome. For some people and or partners, it's not welcome. And so I always have that conversation. I don't think it's a reason not to treat in those situations. I think it's important to get people to be their best selves, but being sensitive to how it might affect how they behave. And so I'll see people like that quite frequently early on, and really have those conversations. How is it going? How is sexuality? How is change in sexuality? How is change in how is this affecting your relationships? How does this make you feel? Is it good? Is it bad? That kind of thing. Generally speaking, I don't believe I've had one person who says, I'm not doing testosterone, I don't like the way it works. But I think it's really important to have those conversations and help people through it. Now, in the more sort of typical case, later onset, we're treating somebody who is later, we're treating somebody who has who maybe obesity is the primary problem. It would be unusual to have a negative behavioral experience. And so there, I'm looking primarily for the benefits, and it takes a little while to work. So we'll see people back in maybe 8 to 12 weeks. And we're looking for reversal of the reasons that they had the testosterone measured in the first place, which would be fatigue, blah, depression, lack of drive, and most importantly, again, lack of sexual drive and sexual function. And typically, you'll see these things reverse by about that 8 to 12 week window. Now, levels. We talked about the fact that the levels are so challenging to measure in the first place. We didn't stress in the evaluation that the level in native testosterone changes dramatically through the day, right? So the levels that we usually look at are first thing in the morning and fasting, should be first thing in the morning and fasting. By the evening, the testosterone would be quite low. That is not the case when testosterone is supplemented, so that's less important. But I, generally speaking, don't bother measuring levels, because if you measure the level 4 or 5 times in a row, it's going to be quite different day to day, particularly with the gel, because of absorption differences day to day, and also with the injections, because there is a peak and a trough. So generally speaking, levels, I tend to measure levels when the person's not responding. I want to make sure that they're getting at least some testosterone in the system, some benefit from it. We'll also measure levels, particularly with the injections. One of the complications of testosterone is what's called polycythemia, high red cell count. And I want to make sure that we're not over-treating people to cause that problem. But if somebody comes in and says, this is great, everything's reversed, I feel wonderful, particularly with the gel, I will typically actually not bother measuring levels, because that response is ultimately what matters.
Right. Yeah, and you brought up a really good point with the side effects, and everything that we have discussed so far, for the most part, is treatment and evaluation of people who have a real, true deficiency that in most cases is not reversible without treatment. So there's a huge difference between replacing something that's not there, or replacing something that is hardly there but not enough to kind of define normal function, versus just using a huge dose when you're already okay, and you get into abusing, and you're just kind of taking things in your own hands. So the risks, obviously, like you said, I mean, your blood counts will go up, your lipid profile will be worse. It can put some strain on the liver. Your risk for cardiovascular disease is much higher. Like you said, aggression and sexual desire and function will be much, much higher. And then also, the male pattern baldness, acne, prostate hypertrophy, hyperplasia, those problems.
You're talking about abuse now. You're talking about
Abuse,
yes,
yes. Which is a huge problem, and I didn't necessarily have this planned at first, but something I wanted to discuss was, I personally get so many people, new patients who come to us from these clinics, who were getting testosterone pretty much just from, they saw someone, I don't feel great. Okay, no evaluation. You start taking a huge dose of testosterone weekly, or even twice a week. And we see them, and it's been a year or 2 or 3 or whatever, and they've been on such a big dose for such a long time, where they're pretty much dependent on it now. Or at least if they want to get off, it's going to be a real pain in the behind, if that's even possible. What's your kind of approach to those folks, since we do have a fair amount of them now?
Well, so we talked about a little while ago, you're a relatively young person coming in on testosterone, otherwise pretty healthy, just feels much better for it, right? Even in a reasonable dose. Um, so where you taking it now is a little further, somebody who is essentially like that, but has been given huge doses because if a little is good, a lot is better. And as you, I think, said, that will eventually completely irreversibly suppress, or pretty much irreversibly suppress, the person's own testosterone. So now we're stuck. And um, one of the things that, as you well know, we pride ourselves on is being holistic in our approach to medicine. And holistic to me means taking the whole person. So here's a person, as you just described, they've been abusing testosterone. They're coming in for some reason, and how can we help them? How can we help them be better, be healthier? Um, Occasionally, these men, or maybe not occasionally, frequently, these men will come in and say, I really need this really really high dose every week. It is what it is. I need it. I can't live without it. Yada yada. I will not, and you will not prescribe these high doses to people. On the other hand, recognizing that after several years of high doses, it may actually not be possible to get a person off. Um, we've certainly had people that we help to get back to reasonable doses. And, there's one memorable couple who came to see me, I don't know how many years ago now. They came together, they really wanted help getting off these. Well, he was on the high dose testosterone, she was not, but she was suffering the consequences with him, the aggression, the bad mood, everything else you talked about. And it's not easy, but he wanted and she wanted to help him get down to a reasonable dose. And over about 6 months, we were able to do that. So um, I think if somebody comes in and recognizes that this is not something they want to keep doing, um, do we help them? Absolutely. Do we keep prescribing the high doses? Absolutely not.
Right, right. And we are definitely challenged with that right now because I was, like I said, I probably get one of these people at least every other week or so, if not more frequently than that, because
Yeah.
these
And many are not ready. Many are not ready. They're not asking to be helped to a reasonable dose. They're
right,
asking to be continued on these mega doses, and that's not healthy. And obviously, we do not become complicit in hurting somebody in that way.
right, right. And often what I tell these guys is, on these doses specifically, I mean, it's hard to say whether if they're taking it and there wasn't really a problem to say with if it's a low dose, whether that's really affecting their longevity to like a huge measurable degree. But if you're on these huge doses, you inherently are not going to live as long as you could if you didn't do this. And some people that could be a couple years, and some people it could be much longer. Depends on their genetics and their family history and whatnot. So a lot of a lot of not so fun conversations that take place in the office sometimes. But anyways, and another thing is specifically to that is a lot of these people will use or they'll be prescribed these aromatase inhibitors. And if people are listening and remembered what we said about 15 minutes ago or so, aromatase is the enzyme that converts testosterone androgen into estrogen. And what these other practices are trying to do is they're trying to eliminate that process by blocking that enzyme. What that inherently does is it pushes the estrogen very low, which is extremely dangerous in most men, women too, who have to use them for breast cancer therapy or other reasons. Pushing the estrogen low is extremely terrible for your cardiovascular system and increases the risk for those bad things like strokes and heart attacks even more than just using the testosterone. So if you're listening and you're using one of those, you should probably not be doing that. Not advice, but you should be evaluated by someone and have a talk.
Absolutely, Isaiah. I mean, I think abusing anything is not a good idea, right?
Right.
And one of
Yeah.
the challenges, though, one of the challenges in all this is that there is not a lot of good research either. So
Right.
you were equivocating on how much does this actually impact longevity or whatever, and I think full disclosure, I absolutely, like you, worry about how this is going to impact people over their lifetime, and certainly that the suggestions and what we're seeing in terms of lipid profile and so forth is very, very concerning. But we don't have research showing, first of all, we don't have research that shows what happens to people when they use very high doses for a very long time, because it's not ethical to do that kind of research.
Right.
But I think on first principles, absolutely, right? Abusing anything is not a good idea.
Right. Well, we do have a fair sample size of people that do that, like the pro bodybuilders and the weightlifting and whatnot, and unfortunately, a lot of them fall over dead at like 40, 45, 50 from cardiovascular
Right.
problems, which kind of further reinforces the point. But those guys are also a really terrible example of that because they're also using tons of other stuff, and they're at very high body weights, which that variable alone really pushes all that stuff up by magnitudes. Um, Not good. So don't abuse steroids and be super overweight. That's a takeaway there. Um, okay. Anything else that you want to add to any of that specifically? Anything that we have discussed or we haven't touched on that you think is an important talking point?
I think as I let me just maybe summarize, right? And that will maybe help me answer the question, and you can chime in because I'll probably miss something. But the one of the main points is that the relationship between the pituitary and the testes is similar to other things we've discussed. And when the testes fail, it's really easy to diagnose because the message from the pituitary tells us that. Um, then the second thing to say is that the vast majority of people with low testosterone, however you measure low testosterone, however you define low testosterone, have a problem with the pituitary hypothalamic message. And that can be due to an actual physical problem like a pituitary tumor, sometimes secreting prolactin. So it's important to remember to look at that possibility. I think the third thing would be that, again, the vast majority of people that we see with low testosterone have relatively non-specific symptoms. Often this is associated with obesity. And there is evidence that in some people, at least, or maybe in most people like that, giving testosterone is helpful. We didn't emphasize you talked about it, but we didn't emphasize that you can reverse the problems with controlling the obesity. And whether that's done through lifestyle or a combination of lifestyle and medications, that actually may be the better treatment um, than giving testosterone. Um, and then there is the group of men who really don't look like they have a problem. Levels are pretty good. They don't have the obesity, but somehow they get on testosterone even in reasonable doses and they feel better. And that in many ways is the most challenging group. We see a fair number of them because of, my friend told me, my neighbor told me, my whoever told me, get my testosterone measured. They get it measured, they get some, and then they feel better. And then what do we do? And um, this becomes a philosophical, ethical issue to some extent. And as you know, we're planning another discussion of this very point with Dr. Mark Stevens from the Hershey Medical Center to think about the ethics of this particular situation scenario. So more to come on that. So I think that's in summarizing. I think
Right.
I don't think there's anything else to say right now today.
Right.
Did you hear anything that I missed?
No, and I think bottom line, if you're a man listening to this, or if you're, somewhere in that age range listening to this, and you have those things, you're experiencing those things, it's very reasonable, and you should be evaluated. But the thing is it's as we discussed, it's very rarely black and white. And, you have X, therefore Y is the way we approach the problem. We approach this problem very similar for most people, but, treating one person versus treating another, it is going to depend on what's going on in the clinical picture and whatnot. And the other thing is what makes this so challenging is we didn't really talk too much about is that, the hypothalamic pituitary testicular axis is a really, really tough axis to get going again once it's been suppressed. It's not like thyroid hormone. You take a bunch of thyroid hormone one day and a couple of days later, you're completely fine. The brain kicks back on. These are very, very, very powerful and dangerous chemicals that can affect you lifelong. And that's often something I'll say to these people is, if you do commit to this, and this is something we move forward with, there's a real good chance that you're going to have to be dependent on a needle and a vial the rest of your life. Do you want to go through airports, having to take this stuff with you on trips? And, do you want to be explaining to TSA all that stuff and explaining to everyone else? And it's not just like you take it for 3 months and, you're back to normal. It's like, no, this is something you're going to have to commit to most likely for a long, long time. So that's a very important question, I believe.
One quick caveat to that. So short-term use, you can stop and you go back to where it used to be, right?
Right,
So
right.
this is one of the reasons we do occasionally do a therapeutic trial where somebody just feels miserable, not sure whether they should or shouldn't. Take this for 3, 4, 6 months. I didn't really help. You don't love it. You can revert. That's completely
Right,
reversible back to
right.
baseline.
Right. It's a low cost lunch. It's not a free lunch, but it's a low cost lunch. But in the bigger picture, you're probably, you're probably going to have to use it for the rest of your life. So,
Yeah.
weighing of options there. Okay. Anything else at all from your perspective?
No, I think we covered it pretty well. It's a confusing, large topic with
It
a lot
is.
of moving parts. So I'm hoping that this make some sense to people, and I'm looking forward to our discussion with Dr. Stevens
Yes.
about
Yeah.
some of the ethics of this.
That'll be a great discussion. And if you are listening to this, we do discourage people from resorting to the online clinics, because remember, those clinics they're trying to sell something. And all healthcare is obviously a business, but they're really trying to sell a couple of products, and that's kind of what it comes down to. So we would encourage you to get evaluated by real people with real experts and people who are actually in the field of endocrinology if you want your best bang for your buck and you really want to find out a problem. But anyways, um, not advice, just education and a suggestion. Okay, I think that's everything. So thanks so much, Dr. Ulbrecht, for coming on. And like you mentioned, we'll have Dr. Mark Stevens on at some point when we get this whole schedule thing figured out, more for the ethical side of the treatment and how the social side really plays into it. So thanks for the chat, and until next time.
Good to see you.